What is herd immunity? How do individual choices affect population health? Can we eradicate infectious disease? All of this and more on today's episode of The Secret Life of Numbers.
Welcome to the Secret Life of Numbers podcast, the podcast where we dissect everyday numbers and statistics to find the stories behind them.
Each episode, we take a number or statistic and break it down. We will tell you where it comes from and what it means for you. Along the way, hopefully we will inspire you to think about the numbers in your own life.
I'm Levannia, your data scientist on call. I'll be breaking down the numbers.
I'm Lindsay, your data translator. For when Levannia gets too technical on us, I'll be breaking down the rest.
All right, let's jump in. So today, we're talking about herd immunity, which is the last in our 3-part mini-series about vaccines.
I'm a little sad to be leaving behind our world of infectious disease and vaccines.
Yes, this really is your wheelhouse, isn't it?
I do like it here.
I'm really excited about this episode because it kind of leaves us where we began with Rnaught. But before we get there, I feel like I should provide everyone with the definition of herd immunity.
Yes, hit us with it.
All right. So this definition comes from the WHO, the World Health Organization, and they say that herd immunity, also known as population immunity, is the indirect protection from an infectious disease that happens when a population is immune, either through vaccination or immunity developed through previous infection. And also, the WHO goes on to say that they support achieving herd immunity through vaccination, not by allowing a disease to spread through any segment of the population, as this would result in unnecessary cases and deaths, as we discussed in vaccine efficacy versus effectiveness when we talked about natural immunity versus vaccination immunity.
As a refresher, if you haven't heard that episode yet, the risks of getting a disease are much greater than any risks associated with the vaccines. And it can also lead to unnecessary deaths and outcomes. And people who might not be able to get vaccinated or might not be able to produce a robust immune response to a vaccination.
Yeah, so I guess having herd immunity kind of protects those individuals in a population who can't get vaccinated because they have their own risks.
For example, there's some vaccines that are developed in chicken embryos. And some people, if they're allergic to eggs, for example, or chicken, they might not be able to take the vaccine. And people who are immunocompromised can take the vaccine and should take the vaccine, but might not be able to if it's a live vaccine.
Like a live attenuated vaccine, for example.
Yeah, because to them, in their weakened immune system state, the attenuated version, which basically means they tamped it down, so it's not as strong, but it's still alive.
Yes, exactly.
It might be strong enough for them to be a full-blown case. So those are the people we want to protect.
It wouldn't be a number section if I didn't get to talk about a formula. I'm always very sad when there are no formulas. The formula for calculating herd immunity is actually really simple. So there's a herd immunity threshold, and then after this threshold, so after this percentage of the population is vaccinated, theoretically, the population has herd immunity.
Mm.
So to calculate the threshold, the formula is equal to 1 minus 1 divided by R0. If you remember, in our first episode, we talked about R0, but I'll give you a refresher on what that definition is. R0 represents, on average, the number of people that a single infected person can be expected to transmit the disease to. We sometimes say that R0 is the average spreadability of an infectious disease.
Is spreadability a real word?
I put it in air quotes.
I love that. It makes so much more sense, though, than saying R0. Like, it's the spreadability. It makes sense.
So if you go to this formula, for example, if you have a theoretical disease that has an R0 of 20, so that's pretty infectious, right? That means on average, if I have this theoretical disease, I'm going to infect 20 other people. 1 divided by 20 is 0.05. 1 minus 0.05 is 95%. Your herd immunity threshold. So people who have immunity either through vaccination or natural immunity will need to be 95% of the population.
I'm going to take what is measles for 200.
Measles is pretty high in terms of its Rnaught.
I think it's around 20.
Last I heard it was like 18, 20-ish. But for example, if you have another fictitious disease with a lower Rnaught, let's say 2, so that means if I have this fictitious disease, I infect 2 other people, 1 divided by 2 is 0.5, 1 minus 0.5 is 50% of the population. So that means you would need to have 50% immunity, either through vaccination or a natural acquiring of the disease in order to achieve herd immunity in the population.
There are assumptions along with that model, though, right? Because I assume that the assumptions would be, but I'm assuming that there's some sort of caveat of equal mixing in there.
So it's important to realize that your Rnaught, it can still change, especially if you're like still learning about the disease. So it's not set in stone. And this is something that we saw with COVID. As your Rnaught changes, also your herd immunity will change too. So I would say that it's less of like a strict barrier. It might be around this calculation, but it might not be strictly that percentage.
Right. And a caveat with herd immunity is, I think it's one of those times in public health and medicine where more is more.
Yes.
Like ideally, everyone would be immune.
I think it's important to think about herd immunity because getting vaccinated is one of the few medical choices that not only benefits you, but benefits the people around you or also protects them. So even though a population can have herd immunity, if there's like pockets of unvaccinated individuals, those people in those pockets are still at risk.
No, that makes sense. And I think that's what I was trying to get at with the mixing too.
All of these things, like all of these numbers that we calculate to explain vaccines, they're all estimates and approximations. When you get out there in like your local populations, your local communities, if the local pocket doesn't have the immunity thresholds, then you won't have the benefits of herd immunity.
I guess you also have to think about the scale, right? Like you can think about herd immunity at a country level. In Canada, you can think of it as a province level, but you can also think about it at a community level.
Yeah. Another assumption in this calculation for the herd immunity threshold is that when you use Rnaught, you assume that everyone is susceptible to the virus in your population, but obviously that changes as people acquire the infection and gain immunity. So sometimes instead of Rnaught, epidemiologists use a value called R effective, and that is meant to incorporate or take into consideration the changes in susceptibility to being infected in the population.
Okay. Because that's it too, is like the thing with models is things are always changing.
Yeah, you can never really tell if your response was quick enough or aggressive enough or fast enough until you're on the other side. While we're here, we're doing the best we can, but we won't know if it was enough or if it was too much until we have hindsight.
I think oftentimes too with public health, you often don't know if you've overreacted. You only know if you've underreacted.
Yes. Can you overreact when it comes to public health? I mean, perhaps you can, but I would much rather an overreaction than an under.
I agree. Like everyone has their own individual risk tolerances and risk thresholds.
All right, so we've talked a little bit about herd immunity and how it's calculated, but herd immunity is really an example of vaccines and how effective they are and how we can eradicate diseases, like the case of smallpox.
Yes, exactly. And this is one of my favorite stories in medicine because it's a pretty impressive feat to have eradicated an infectious disease.
It is. I don't know if it's an oldie yet, but it's definitely a goodie.
I hope it's not an oldie. I hope we can reproduce those results in other scenarios. One thing that I think is interesting is like we grew up in a world without smallpox.
Yes, you and I, we grew up in a world without smallpox. But I mean, my parents, they still have that smallpox scar that shows that they got the vaccine.
Yeah, exactly. We're kind of part of one of the first waves of people who haven't had to worry about it, which is magical. So let's talk about what is smallpox and how we eradicated it, because this is really a story that spans most of human history. Smallpox is an infectious disease that's caused by a variola virus. It produces fever and this very distinct progressive skin rash. Smallpox has a pretty high mortality rate, so 30%, which is quite high. So that means 3 out of every 10 people that get smallpox will die. And those that survive aren't always back to normal, so there can often be severe and permanent scarring from the pox and pustules. And some people are actually left blind by the virus.
Yeah.
The Rnaught of smallpox is quite infectious, so it's 5 to 7.
All right.
Middle of the pack, but like not as high as measles, but up there.
I feel like when it comes to Rnaught, smaller is always better.
Yes. We aren't exactly sure where smallpox came from, but findings on Egyptian mummies actually suggest that it's been around for at least 3,000 years.
Wow. I didn't realize it was that old.
Yeah, it's an elderly virus.
So maybe smallpox is the oldie and the story is the goodie.
Yes, I like that. The earliest written descriptions of a smallpox-like disease were from China in the 4th century. It's really been part of humanity for a very long time. And one thing that's actually very interesting about smallpox is only humans can get smallpox, but other animals have their own poxes. So there's like mouse pox that like mice can get. There's camel pox that like camels can get.
Okay.
Chicken pox is part of the herpes family. It's a different kettle of fish.
All right. Kettle of fish.
How do we eradicate a virus? DIY guide. Okay. Early control efforts.
All right.
This takes us back to 1796. Dr. Edward Jenner is an English doctor who noticed that milkmaids weren't getting smallpox as often as other people.
Milkmaids being women who milked cows.
Yes, because many of them had had cowpox.
Okay. And cowpox is like a pox disease that they would catch from the cows.
Yeah, exactly. It's like our camel pox or our mouse pox. It's a cowpox. So Jenner hypothesized that exposure to cowpox was protective against smallpox. And this is where his research ethics got a little hairy.
We are definitely very strict now in terms of our ethics and our ethics approval. And that's because we've learned from the lessons of those who have come before us. So the history is not always perfect and rosy, but we're always trying to improve.
Yes. So what he did, and there was this process back then called variolation, which was an early form of vaccination. And so basically what they would do is you could take a small amount of material from like a pustule of someone infected by a disease and scratch the material into the arm of someone else who is naive to the disease, or have them inhale it through their nose or something. And they might develop the disease, but it's milder. So it's kind of like a live attenuated basic vaccine.
The origins of live attenuated vaccination, perhaps.
Exactly. So the way that Edward Jenner tested his theory about cowpox and smallpox was he took material from a cowpox sore on a milkmaid's hand, and they even have her name. Her name is Sarah Nelms.
Thank you for your service, Sarah Nelms.
Unsung hero right there. And they inoculated it into the arm of his gardener's 9-year-old son, James Phipps. Thank you as well to James. I know you probably didn't have a choice in this, which is not okay.
Yes, not okay. I agree.
So a few months later, Jenner exposed Phipps, probably still a 9-year-old boy at that point, maybe 10. They exposed him to the variola virus, but then he didn't get smallpox.
So they purposely infected this young man, James, with cowpox. And after he recovered, they exposed him to smallpox.
Yes, and he didn't get it. So what they did is they published his findings in a paper in 1801 called On the Origin of Vaccine Inoculation. And vaccination was really birthed out of that and replaced variolation. So we got a lot better at the inoculation. We shifted in the 1800s from doing variolation with cowpox to using a vaccinia virus, which is similar.
Okay. Is it similar to the cowpox virus?
Well, they would all be similar, but it would be one that produces that immune response that you need to give some protection to smallpox. And of course, vaccine development continued. And then in 1959, the WHO started trying to plan how we could get rid of smallpox, and they started the Global Smallpox Eradication Program. But it wasn't super successful because there wasn't a lot of funding.
Yeah, it had a rocky start.
Kudos to them for not getting discouraged because they kept at it. So nearly 2 decades later, they launched the Intensified Eradication Program, and labs were able to produce high-quality freeze-dried vaccines. And they had some tools and strategies that really helped them combat disease. They established case surveillance systems. They had mass vaccination campaigns globally. They had a special bifurcated needle.
Yeah, that's the one that left a scar, so you would know if you were vaccinated.
Exactly. And they also did this strategy called ring vaccination. So if one case popped up, they would vaccinate all around it. So within like a certain radius of that house, they would go to each house and business and vaccinate people who were there.
And you can imagine that as like almost a trench surrounding the outbreak so that it can't pass the borders.
Which is quite impressive that they were able to respond to the infections on the scale that they did.
I'm guessing freeze-drying the vaccine or having a freeze-dried version of the vaccine really helped in allowing it to reach so many individuals, because I'm guessing it wouldn't have to be refrigerated at that point.
Yeah, and that's a big part of the problem, is that in some areas of the world, they had already kind of rid it locally. So they didn't have smallpox endemic locally. But then in other places, like for example, places that were more rural or globally kind of less developed, there's just very practical barriers like refrigeration to getting a vaccine somewhere.
Because the entire time it has to be kept cold, like its entire path to your arm. If it's not freeze-dried, it needs to be in a cold chain.
Exactly. And it worked. There's 2 different types of variola which cause smallpox. So there's major and minor. The last case of variola major was a 3-year-old in Bangladesh in 1975 who isolated at home. There were house guards outside to make sure that they didn't leave. And then they did the ring vaccination within a 1.5-mile radius. And they also visited every single person within a 5-mile radius to check. The last case of what's considered like naturally acquired smallpox was variola minor in 1977 in Somalia. And the person who was infected, his name was Ali Malin. I might have not pronounced that correctly, but he worked at a hospital and he actually survived and worked on the polio eradication campaign, but unfortunately died of malaria in 2013 while he was working on that campaign.
How long did it take to eradicate smallpox? Like, how long was the WHO out there vaccinating individuals?
Well, the Global Eradication Program started in 1959, and then it was renewed with the Intensified Eradication Program in 1967. So about 10 years.
So it's no small feat to eradicate a disease.
It's no small feat to eradicate smallpox.
And that's only an Rnaught of 5 to 7. Because now we talk about eradication of measles.
Yeah.
And that Rnaught is like 18 to 20-ish, I think.
Yeah, and people are also so much more global nowadays.
Yeah, globalization is another factor because you can move around much more easily.
Yeah. Unfortunately, though, there was one last case of someone dying of smallpox, but it wasn't acquired naturally.
Oh, I think I've heard of this. This was someone in the lab experimenting with smallpox.
Almost. It was someone who worked 1 floor above the lab.
Through the ventilation?
Well, they aren't sure if it was because smallpox can be transmitted through airborne means. So they weren't sure if it was the duct system or direct contact with colleagues and things in the microbiology department. In 1978, Janet Parker was a medical photographer at Birmingham University Medical School in England, and she worked 1 floor above the medical microbiology department, and there was smallpox research going on, and she became ill and died a month later. Her mom also developed smallpox from that, but she was vaccinated and she survived. So May 8th, 1980 was the day that they officially declared the world free from smallpox, and this was almost 200 years after Edward Jenner hoped that vaccination would rid the world of smallpox.
A long timeline, but I think worth it.
One of the things that's interesting is smallpox is eradicated, but it still exists.
Yes, that's true.
There's 2 locations in the world which officially store and handle variola virus under WHO supervision. The 2 official stores are at the CDC in Atlanta, Georgia, in the United States, and the Vector Institute in Kosovo, Russia. One of the things that's interesting but also a sad reality is that we can't eradicate all infectious diseases.
Smallpox, I mean, it wasn't easy, but it's easy in the sense that it's only in humans. Like if it's also in, I don't know, bats, you would also have to immunize all bats in order to prevent it from changing in the bats and reinfecting humans. Because humans are the only reservoir of the virus, you only need to eradicate it in humans to consider the virus eradicated.
Exactly. One thing that's fortunate with smallpox is from the time that you get infected to the time you show a rash is very short. So you don't have as much time to like go to school, like bop around.
Infect other people.
And like theoretically, we could eradicate the world from polio. And there have been efforts on the part of, I believe, the WHO as well, to eradicate polio. But the problem with polio is it's not immediately obvious that it's polio. And there's that longer incubation time. So it becomes harder and harder.
Yeah. I have heard that we are also trying to eradicate measles as well.
Yeah. The problem with that is there's a really long time between exposure and development of symptoms. And people are contagious before they have a rash. But it's still theoretically possible because we're the only reservoir.
Even though the Rnaught is very high.
Which actually leads us nicely into like what are the consequences of lower vaccination rates or like waning herd immunity. So there's an interesting but unfortunate epidemic in Samoa and other Pacific islands of measles. The Samoan Ministry of Health officially declared a measles outbreak in October 2019, and they saw this resurgence of measles. And as of January 22nd, 2020, there's been over 5,700 measles cases and 83 measles-related deaths in the region, which is very high for a vaccine-preventable disease. What's really unfortunate is there was this kind of resurgence of hesitancy with vaccination because it was partly linked to this mistrust in the safety of it because there were 2 vaccine-associated pediatric deaths, so kids who died after vaccination, that resulted from medical negligence. It's very understandable if that's happening at a clinic that's giving out the vaccines, why would you want to take your child there, right? Like you don't know what's going on.
I can definitely understand, like if there are vaccine-related deaths, especially in children, I think it's fair to be a bit concerned. But it's also important to understand that here, in this case, it was caused by medical negligence.
It wasn't an adverse reaction to the vaccine. I think they don't go into a ton of detail. This is in an article from the Lancet Infectious Disease. But my understanding of the situation was that it wasn't a reaction to the vaccine. It was an unfortunate case of negligence and not actually providing the vaccination that you said you were going to provide. What happened is immediately there was a recall of all MMR vaccine and the suspension of the National Immunization Program in Samoa while they investigated this issue. Because they didn't know was it a storage issue? Was it like what was going on? But it was medical negligence and not actually the vaccine. The conclusion, the WHO's Global Advisory Committee on Vaccine Safety observed that poor communication and the blaming of individuals rather than conducting like a systemic analysis of the problem had a detrimental effect on the vaccine program because there was a time of almost a year where they had pulled the vaccine, so people weren't getting vaccinated. And as a result, they used to have 99% coverage of children younger than 1 year with 1 dose, and that fell to 40%. Mm-hmm. And second dose coverage fell from 87% to 28%. So they were well below that 95% that you needed.
Yeah.
So, Levannia, it's science seed time.
It is.
Each episode, we like to give our listeners something to think about. A science nugget to help you think more critically about the numbers, statistics, and really the science that you hear every day. So, Lev, why don't you take it away?
Today, the thought that we wanted to leave you with was that at your herd immunity threshold, the population isn't magically immune to the disease. It's very much a gradient. And as infectious diseases evolve, that herd immunity threshold will change. And as we discussed, there can also still be local pockets of unvaccinated individuals in which the disease can spread.
Yeah, and I think that's kind of where we're at right now with COVID-19 in Canada. We have decent coverage of vaccines, could always be better, but in a lot of places they've removed mask mandates and that sort of thing, but still at an individual level, I can just speak from personal experience. Like, there's some situations where I still feel more comfortable wearing that because transmission is high in my community or whatever it might be. And that's kind of the power of knowing the numbers, too, of what the epidemiology of a virus is in your own area.
Yeah. Perhaps the final thought is that infectious diseases and viruses, they're always evolving, and so too must these calculations and these numbers.
So too must public health.
Thanks for listening, everyone. You can find us on Apple Podcasts, Spotify, Google Play, or wherever you find your podcasts. You can find the references we use for this episode in our show notes. A special thank you to Julian Bertino, who does our sound editing and music.
If you have a moment, please rate us and review us on Apple Podcasts and Spotify. It really helps our podcast reach new listeners. Have an idea of what number we should cover next? Want to learn more about what we talked about today? Follow us on Instagram at The Secret Life of Numbers.
We'll catch you next time on The Secret Life of Numbers, where the numbers can run,
but they can't hide.